Hello, my name's Graham, and I do some training for Dovetail Medical Events. Today, we're going to have a look at understanding or reading the blood test results. We'll have a look at some of the basics around that. I deliver some training for Dovetail around interpreting blood tests and ECGs. So we do specific training on INR and warfarin, and we also deliver training on basic blood testing and advanced blood testing. So we look at full blood count, look at patterns of anemia, iron deficiency, B12, folate. We look at CRP, C-reactive protein, and inflammation. We look at platelets and clotting. And then we delve into a little bit more detail around liver and kidney. And then we also look at long-term condition management, so things like diabetes, lipids, and the use of statins, hypertension, heart failure, chronic kidney disease, and then we look at some thyroid function and bone profile. The difference between the days is one is more aimed at primary care, practice nurses, HCAs looking at long-term condition management, and the other is more advanced practice. Although it's called advanced, doesn't mean it's any more difficult. It's just we have a deeper and wider review of the material. So looking at a more complex comorbidity, polypharmacy, and looking at escalating some of those values that might be slightly out of range. So the normal course content is split into two components: the hematology, where we'll talk about the full blood count, the white cell count, and differential markers around clotting and coagulation. And then the biochemistry, kidney, diabetes, cardiac markers, liver function, and an overview of the resources and material. All of the training is very interactive. Lots of engagement with the group, lots of questions, lots of case studies. We do some visual learning, even though it's remote. We do some reflective learning, some case studies, and we also have a look at some of the written material on the slides. There are some additional resources and references that are very helpful. So one is a website called Lab Tests Online. And this is an A to Z of any blood test you'd ever want to do. It's made by the NHS, so it's peer-reviewed, evidence-based, and it's effective in A to Z of any blood test you'd ever want to do. So the website address is labtestsonline.org.uk. It's a really helpful resource to have a look at if you're interested in blood testing. It's also part of the NHS reporting system, so it can help with explaining the results to patients. And if patients get their results on an app or on an email, then it's really helpful to link across to that. I've written a textbook, which is called Blood Results in Clinical Practice. There's a picture of it. It's got some red blood cells on the front. You might have seen that. Only get 50p in royalties, so I won't be retiring off to Barbados. So we'll be looking at the NICE guidance. If you're in a different part of the UK, if you're in Scotland, Northern Ireland or Wales, or a bit further afield, then have a look at your national guidance for each blood test. And then have a look at how that's locally applied. So what's your local trust guidance, your local PCN or GP guidance, the interaction between primary care and secondary care. So rheumatology might have a share care delegated list, or pharmacy might have a list or a protocol for you to follow. So have a look at how it's locally applied, because it is guidance at a national level. And at a local level, it might be slightly different because you might have a different GP set up. The nearest hospital might be quite a way away. The nearest expertise might be in a different hospital. So have a look at how your national guidance has been locally applied. And with all of the training, It's not medical advice specifically, it's more of an education CPD workshop. So the main aim of all of my training is to not do the protocol pathway stuff, although we need to talk a bit about that, but to have a look at treating the person rather than the numbers. So let's take a holistic view of the patient and have a look at how it all fits together. So we're going to take the blood test and we're going to link it to the underlying anatomy and physiology. So what would a fit and healthy liver look like? What would a fit and healthy kidney look like? How might that be different if they were diabetic? If they started on an ACE inhibitor like Ramipril? If they developed nerve damage? It's kind of how would all this fit together? Okay, so in this session, we're going to have a look at the results itself and kind of how we would look at interpreting them. And so to start off with, the blood is split into two different groups, the biochemistry and the hematology. So the biochemistry contains all of the chemicals in the blood. So that's going to be things like sodium, potassium, liver markers. And the hematology contains all of the cells. So that's going to be things like red cells, white cells, and platelets. And collectively, they're normally called the full blood count, FBC. And it's approximately a 50-50 split. So about half of our blood is liquid, and about half of our blood is cells. So that takes us to a very simple blood test called hematocrit. So if you request a full blood count, there's a blood test marker called hematocrit or HCT. And this measures what percentage of all of the blood is red blood cells. And you can see from this diagram, it's about half. So about 45% of all of our blood is red blood cells, which is why your blood's red. Around 5% of all of our blood are red blood cells. About 45% is red blood cells. About 5% are white blood cells and platelets. And then the remaining 50% is liquid, plasma, fluid, whatever you want to call it. So about 45% of all of our blood is red blood cells. About 5% are white blood cells and platelets, and then the remaining 50% is liquid. So in the training on the day, I would ask the group a question, which is what I'm going to ask people watching this snippet now. In your experience, what would make hematocrit decrease? So if you want to pause this recording, have a think about that. What would make hematocrit decrease? So that would normally be things like anemia, blood loss. So a reduction in the number of red blood cells. However, because hematocrit is a percentage value, it could also decrease if you had more white blood cells. So if you imagine a pie chart that's got to add up to 100, as you increase the white cell component, can you see the percentage of red cells will start to decrease? Similarly, if you had more fluid in your blood, so if you were retaining fluid, like in heart failure or in syndrome of inappropriate antidiuretic hormone, if you got more fluid in your blood, that would artificially or would temporarily dilute hematocrit value. So hematocrit's okay. but it can be affected by things other than the number of red blood cells. So it would be helpful to have a marker that tells us about the number of red blood cells, and that's called red cell count, or RBC RCC. And this measures the number of red blood cells. So this is a count of how many red blood cells you've got as a physical number. This is helpful for things like chemotherapy, bone marrow disorders like leukemia, myelomas. This is measuring the production of red blood cells. And then finally, we have a different marker for red blood cells, which is called hemoglobin. So hemoglobin is the oxygen carrying protein in red blood cells. So this is the one that's going to make you feel tired if it's low. So in most clinical settings, particularly in primary care, hemoglobin is the main marker to check. It's the most linked to symptoms. So SX means symptoms. So if somebody's tired all the time, TATT, they're very likely to have a low hemoglobin. It's also the diagnostic marker for anemia. It's also the diagnostic marker for things like blood transfusions. So there are 3 different markers for red blood cells: hematocrit, which measures the percentage, red cell count, which measures the number, and then hemoglobin, which measures the oxygen carrying protein. So again, in the training session, I would ask the group to explain what is the difference between hematocrit, hemoglobin, and red cell count, and which is most relevant in your practice and in your setting. Okay, the final part of this slide is that almost all of our blood tests are actually a concentration. So if I hold up my yellow cup on the screen, this is filled with water. So if I took a teaspoon of salt and mix this in, I'll have a cup of salty water. And this is what we actually measure in the blood test. So although we shortcut the language and we say that our person's got high sodium or low potassium or high glucose, what we actually mean is they've got a high concentration of this. So again, just to kind of help with that visually, if I write Na on the screen to represent sodium, and let's say this is diluted by 2 water droplets to give us the normal sodium concentration. So that would give us the normal sodium reference range, 135 to 145, something like that. So if your person had heart failure, then they often retain excess fluid. So that could dilute their sodium and they'll end up with a low sodium in their blood, hyponatremic. And the symptoms of that being tired and confused. Additionally, with their heart failure, short of breath. So you can see that hemoglobin can make you tired and confused, but so could low sodium. So we might want to remove some of this excess fluid with a diuretic. By removing this excess fluid, this also often removes sodium. So your person might have low sodium because they're over diurized. So thinking about the cup model, how much fluid have they got? How much water is leaking out the bottom? Is it dragging any of the salt with it? And then how much of the salt teaspoon is being put in? So for example, a lot of older adults, they don't eat much salt. There's not much salt in tea and toast. Is it dietary? Have they lost salt through diarrhea, vomiting, a hot day? And there are lots of other reasons why you might have low sodium, which we explore in the 4 days training. Okay, as we go along in the training, we'll draw these together. We'll talk about them, opportunities to ask questions, reflect. I don't do death by PowerPoint. I don't do artificial intelligence scripts or anything like that. You just got me. I'd rather just talk to you. Any questions or comments, just give us a shout as we go along. Okay, the other thing we cover in a lot more detail is the way the blood was taken. So this could significantly impact things like potassium. So for example, if you want to draw a circle, and this circle represents a red blood cell, almost all of our potassium is inside red blood cells and inside muscle cells. So if the red blood cells break open as part of the collection, this is called a hemolyzed sample and can artificially elevate potassium levels, as can overusing the tourniquet. And if your person is dehydrated or they've not taken the blood in the right order. So we'll explore all of that in the training sessions. So just to summarize, are all the blood tests needed? We can get hemolyzed sample if the blood has taken too long to get to the lab, the order of draw, overusing the tourniquet, and if bottles are underfilled. Again, we'll explore all of that in the session. Okay, the other fundamental thing we do is have a look at the basic underpinning of blood testing. So one of the most important questions we ask is, what are we actually measuring? And we actually measure 4 different things based on the underlying anatomy and physiology. So we'll have a look at cell content, something which has leaked out of a damaged cell. Removal of a waste product, something that should be removed by the kidney or the liver. We'll look at production. So the body is going to make thyroxine, rheumatoid factor, CRP. They're all examples of production. And then we're going to have a look at interaction. So these are 2 things that interact with each other. So for example, a red blood cell interacting with glucose to give us HbA1c. And that could then lead to a conversation around, well, okay, what if your person's anemic? Maybe they'll have less red blood cells and therefore an unreliable HbA1c. So this links the blood test to the anatomy and physiology. So we're thinking about, why have we done a blood test and what are we measuring? When we come to look at the result, we can have a look at 4 key questions. So first question, how far out of range is it? What's the trend data? Have you got any clinical guidance around a level at which it's too dangerous or we need to escalate it? These are called clinical decision limits. Does the result make sense? Are they symptomatic for the blood test? Is it always out of range for them? So can we treat the person rather than the numbers? Can we link blood tests together? So, okay, you've got raised potassium. What's sodium doing? You've got a raised liver marker called ALT. What's bilirubin doing? So can we link these markers back to the AMP? And then finally, why was the blood test done in the first place? So a borderline value in an annual review might be different to somebody who presents symptomatically with the same borderline value. So we might look at symptoms, we might look at annual reviews, long-term condition management. It might be started on a statin, and we'll have a look at your liver markers changing. So knowing why the blood test was done is really, really important. So there are 2 fundamental underpinnings of blood testing. We'll also then move on and have a look at reading the result. And we'll go through some examples of what the results look like. And then finally, we'll have a look at one of the main problems with this is these reference ranges. So first of all, each hospital might have a slightly different reference range. We'll talk about that. The reference ranges normally come from volunteers aged 18 to 35. And finally, the reference ranges do not reflect health. So a lot of patients assume or consider that if you're out of range, you must be unwell. If you're in range, you must be all right. And that's not the case. So this is where we get a lot of confusion potentially around borderline values. So one of the things we'll explore in the training is this idea of a range hangover. So on the screen, you can see this green line here represents health, a healthy patient. The red line represents the unwell patient. These two blue vertical lines represent the reference range that we use in practice. So this is the reference range that we use in practice. Can you see the problem with that? Can you see these people here? Can you see they're out of range, but they're actually okay? They're called false positives. So to help with that, we're going to go back to those 4 clinical questions. How far out of range is it? Is it out of range by a little bit, or is it out of range by a lot? Second question, are they symptomatic? So are they part of this red group or part of the green group? Is it always out of range for them? Every time you measure their value, is it always here, or has it done this? And then finally, why are we doing a blood test on this person? Is it, and then you review for a chronic condition, which might be abnormal but expected? Or is it somebody presenting symptomatically unwell? So in this small snippet, we've had a look at hemoglobin, hematocrit, red cell count, and the impact of fluid on things like sodium, potassium, hematocrit, and we said 50-50, half it's water, half it's cells. For a lot of blood tests, there are different measurements of the same thing. So there are 3 different measurements of red cells. There are different measurements of renal function. And we spoke about the reference range doesn't always reflect health. We'll explore that in more detail. And we also spoke about the 2 clinical underpinnings, what we're measuring and what to do when it's out of range. So hopefully you've enjoyed this short summary, a flavour of what we cover in the training, and hope that it's been beneficial. And if you want to book onto any of the upcoming sessions, then visit Dovetail's website, and I'll hopefully see you again at a future session.